Okay, so that was the first kind of group of drugs. The next group of drugs are drugs that conceptually you are familiar with, but we haven't really talked about them in this context of being treatments. And so we're going to look at pressor agents or vasopressor agents. And so these drugs are really useful in promoting the vasoconstriction that has to go along with other routes of treatment, in this case, fluid replacement in the context of hypovolemic shock. Okay, and these drugs are your adrenergic receptor agonists. And so the clinical conditions where pressors are used include septic and hemorrhagic shock, as well as cardiogenic shock, all of which will be discussed in this next round of cases. And we can also talk about using pressor agents in the context of, really acute, severe heart failure that has, really low blood pressures, and even bradycardias as well. Just kind of some quick terminology. And this, I think, is kind of historically important, and I really didn't know where to put it, so I'll put it in this lecture. Let me slide this window down a little bit. Here we go. So we all know epinephrine comes from the Greek word epinephron, meaning above the kidneys, and that's the site of where epinephrine is made, of course. If you're from the other side of the pond, from the UK, you may have heard of it called adrenaline. Adrenaline is the Latin equivalent to the Greek word epinephrine. So adrenal means above the kidneys, just like epinephron means above the kidneys in Greek. Norepinephrine is an American way of saying noradrenaline, comparing the British way versus the American way. Norepinephrine is really an old medicinal chemistry term to talk about a demethylated epinephrine molecule. And likewise, noradrenaline is a demethylated adrenaline molecule. Okay, and so the way this kind of worked out is that, if you look at the biochemistry, dopamine gets converted into norepinephrine, norepinephrine gets converted into epinephrine. Okay, interestingly enough, as we discovered epinephrine in 1901, and we didn't discover norepinephrine, at least in terms of its chemical structure, until 1946. And so that's kind of how this terminology came about. So I think that's kind of interesting. But anyway, when we talk about pressors, we're talking about epinephrine and norepinephrine. These are your classic kind of pressor agents. These are the endogenous molecules that act as pressors. And what we do is we've made drugs that look like these two neurotransmitters to be of clinical benefit. Okay, and so what we're doing now is we're looking at the adrenergic receptor system and the neurotransmitters that modulate them, and we're going to hone in on alpha-1 again. And so remember we said, alpha-1 blockers make really good antihypertensives. Now we're going to talk about alpha-1 agonists. Okay, and so this is that classic pathway of here's your G protein coupled receptor, the agonist comes in, here's the alpha-1 receptor, and this is in vascular smooth muscle. And there's the signaling pathway over here. Basically, IP3 stimulates this calcium-dependent protein kinase. And essentially what happens is that these activated kinases increase the plasma constant, or the cytosolic concentration of calcium, and that promotes smooth muscle contraction. Okay? And so these alpha-1 agonists, of which epinephrine and norepinephrine are included, promote alpha-1 agonism, which promotes smooth muscle contraction, and that'll increase blood pressure, and that's how you get that pressor effect. Okay, and so alpha-1 agonists do tons of things in all different tissues, and so some of the physiologic consequences to alpha-1 agonism are depicted here. And as we go through all of these different blocks and all these different physiologies, you'll learn about all of these different processes. I just kind of wanted to put this here to kind of be our guidepost. Understand too that there's an I component. So when alpha-1 agonist hits the pupillary dilator muscle, it produces contraction, and this is called mydriasis. And I wanted to show you what mydriasis looks like. So this is mydriasis with an alpha-1 agonist, and here's meiosis, and so that's the opposite effect. So, and not to be confused with this meiosis, even though it's pronounced the same way, the spelling is different. So this is meiosis in the eye, and here's meiosis in your cell and molecular biochemistry textbooks. understand too that when we talk about these neurotransmitters, we're really looking at the ability of epinephrine and norepinephrine to bind to the beta receptors and the alpha receptors systemically. And so I kind of like this depiction, and you can kind of come back to this as we go through the curriculum. But in terms of affinities, norepinephrine has a really potent, a really strong affinity to alpha-1 receptors, which are in the peripheral vasculature, alpha-2 receptors, which are in the CNS compartment, and beta-1 receptors. Okay, the affinity of norepinephrine to beta-2 is quite small, as depicted by this graphic. Okay, in contrast, epinephrine has the greatest affinity to the alpha-2 receptor, which is again central, and near equal affinities to beta-1, beta-2, and alpha-1. Okay, and so I kind of like these diagrams more so than this, but if you're mathematically inclined, this might make a little bit more sense. How I remember it is norepinephrine is not interested in beta-2, and epinephrine loves alpha-2. That's pretty much how I remember the difference between these. So epinephrine, you know, in terms of it being a drug, we can kind of go back to where do we see epinephrine injections? And so go back to allergy. And so people that have allergic reactions to bees or flowers, as well as peanuts, you know, these people will often carry an EpiPen. And there's plenty of politics involved with the price of the EpiPen in the last year. If you remember, that was all over the media. And so epinephrine is a good drug for the immune anaphylaxis, but it's also a positive pressor agent, working through your alpha-1, beta-2, and beta-1 receptors, as well as your alpha-2 receptors centrally. Excuse me. Other drugs that are your classic kind of pressor agents are your non-specific beta agonists. And so here the classic example would be isoproterenol. And this drug is specific for all the beta receptors, beta 1, 2, and 3. And it has virtually no alpha activity. And so we used to use isoproterenol for asthma because of the beta 2 effect, but the cardiac effects caused lots of problems in patients. And that actually led to the development of beta 2 specific agonists, such as salmeterol and albuterol. Isoproterenol, when you administer it initially, will cause a major increase in blood pressure, at least initially, until all of the different various compartments adjust for that. And we typically use isoproterenol in emergencies to positively affect heart rates in terms of like low bradycardias. Okay. Excuse me. I really like this summary slide, and I wanted to give this to you guys at some point during the curriculum, and I think now is kind of a good time to give it. But I think, you know, when I talked about making summary tables for all these different drug classes and their indications and so forth, this is kind of what I had in mind, and I think you guys should be generating these tables by yourself because, excuse me, because it helps you remember it. If you fill it out. But I wanted to put these out there periodically so that you can study off of them. So this is a great summary table. So here's your alpha-1 receptor, and this basically determines the potency of the various agonists that exist. And so epinephrine is more potent on the alpha-1 receptor than norepinephrine, and norepinephrine is more potent on the alpha-1 receptor than the chemically made phenylephrine. Okay, and so then you can talk about the prototypical antagonist, prazosin. That's not part of this lecture, but it is a summary slide, of course. And then here's the tissue distribution of the alpha-1 receptor and the response that goes along with it. And so you can do the same thing for all these different receptors. So I encourage you strongly to start doing these types of tables by yourself. I hope you had started them at least in the previous block when we talked about antibiotics. And you'll see these types of tables coming out throughout the curriculum. If you want to look for these tables specifically, or if you need help generating one, please let me know. But I think that having a series of incomplete tables that you kind of go back and forth to and fill out while this curriculum is going is going to be really beneficial to help you study. Okay, so here's a good example of how you should start looking at some of this. So remember back when we had talked about some of these catecholamines, of which epinephrine and norepinephrine are, we talked about the synthesis of how these compounds are made in the body. It all starts with tyrosine. Tyrosine gets converted into L-DOPA. L-DOPA gets converted into dopamine, and dopamine gets converted into norepinephrine and possibly epinephrine, depending on which tissue. Dopamine also has affinity to both beta and alpha, and of course dopamine receptors. Okay, and so dopamine as a drug is actually really beneficial in the context of shock. Okay, so here's the signaling pathway through some of the dopamine receptors. It's very similar to how beta receptors operate. There is a potassium component to some of the other dopamine receptors that doesn't exist for the beta receptors, but we'll get into that in the CNS portion of the curriculum. But understand that dopamine has positive effects on beta-1, so this is at the heart, beta-2 in the smooth muscle in the bronchi in the lung, as well as alpha-1 in the arterioles and arteries of the kidney, as well as dopamine receptors hitting the dopamine receptor subtypes that exist in the kidney as well. So dopamine's a great drug. It definitely will affect the autonomic nervous system, and its unique properties show really good clinical benefits in patients that have hypovolemic shock. Okay, because of its beta-1 agonist effects, we see increases in inotropy at the heart. And unlike other, and this is the key, unlike other adrenergic agonists, it'll actually increase blood flow to the kidneys. And so this is actually really clinically beneficial. So when you have a patient who has, who's experienced dramatic volume loss, so, gunshot wound or a stab wound or something, there's going to be a very potent vasoconstrictor response that's going to be activated systemically if you use some of these vasopressors like epinephrine and norepinephrine that we had talked about. The problem is that if the kidney itself doesn't get perfusion, it's actually going to stimulate that renin-angiotensin-aldosterone system, and that's going to be the stimulating factor to really kind of exacerbate disease progression, and it's going to make managing these patients worse. And so, for the punchline, what we do is we supply dopamine type drugs because they actually increase perfusion or blood flow to the kidneys, and this is through an alpha-1 and dopamine-1 receptor mechanism. Okay, and so there's a risk of using an alpha agonist to increase the blood flow, leading to kidney failure if the agonist is administered long enough. And so we can kind of circumvent this problem by giving something like dopamine or dobutamine, which has both affinity for the beta receptors, but also the dopamine receptors. And so this is kind of an interesting strategy to kind of save the kidneys by administering this drug. And so it has all of the positive inotropic effects on the beta-1 receptor, but it also causes an increased blood flow to the kidneys, which is really going to be clinically beneficial because once those kidneys have a reduced blood flow, that renin-angiotensin-aldosterone system is going to kick in, and it's going to make management of those patients a lot more difficult. Okay, so this was kind of a brief overview of drugs that can be used for shock. They don't really fit into a specific category, but basically look at the patient's signs and symptoms and see where some of these positive inotropes, such as epinephrine and